So welcome again to this fifth session of this World Congress for Genetic Counseling. In this session, we will talk about the communication process of genetic counseling with the different aspects of both delivering genetic counseling and receiving genetic counseling. First, Jonathan Roberts will give us a talk on the definition or what genetic counseling actually is. Secondly, we will hear Vera Lishenska from Russia, who will talk about different areas of genetic counseling and genetic testing in Russia. The third talk in this session will be Adria Lopez from Spain, who will talk about the counselee's perception of genetic counseling and the results given and how it might be affected by personality. And finally, in this session, Malope Malebo would talk about the healthcare professionals' perception on giving genetic counseling when in a fetal setting, fetal department setting. Thank you.
So just by way of introduction, my name's Jonathan Roberts. I'm a clinical genetic counsellor in the NHS. And I'm also an academic researcher in the Engagement and Society Department at the Wellcome Genome campus. And my PhD and ongoing research has focused on aspects of science engagement, science communication, and using sort of social science methods to research those. And today my talk is going to focus on how research from this field can help us when we're thinking about communicating our professional identities as genetic counsellors and what it is that we do. Sort of one of the reasons I'm kind of talking about this today is that in many countries, the UK and other countries in sort of similar ways, genomics is becoming integrated in mainstream healthcare, which means that aspects of genetic counselling are increasingly going to be delivered by other non-genetics health professionals. And in this context, I think it's important to kind of define who we are, what we do, kind of what the value added is, I suppose, of having genetic counsellors deliver genomic medicine. So, in short, I think you can kind of say, we need to define and communicate our professional identity, kind of get used to doing that, in increasing settings. And I suppose partly this might be for ourselves, because introspection is quite useful in thinking about, well, what is our professional identity? What is it that we do now? What is it we want to do in the future? But I also think it's important to be able to clearly communicate what genetic counsellors do and who we are when advocating for ourselves and our approach to genomic medicine, so that we can retain an important role in the delivery and implementation of genomic healthcare. So in this talk, what I'm going to do is going to just reflect on some of the concepts from science communication research, and then sort of think about how they can help genetic counsellors when we're kind of going about communication of our professional identity, who we are, what it is we do, and they're sort of points for reflection rather than a set of rules. So they're kind of things to think about rather than a kind of series of do's and don't do's. Yeah, this kind of idea of professional identity, I think, I guess we could think about why it matters. I've touched on that at the beginning. But it also kind of comes from, I think, an experience we probably all have as genetic counsellors when, somebody asks what we do, and we often get a sort of blank stare, slightly confused look, raised eyebrows. It's still something that I think, is a little confusing to some people who aren't familiar with the profession. And although it's growing, I think the 2018 estimate was there were about 7,000 genetic counsellors in 28 countries. I mean, that was 3 years ago, so that's probably growing. But you can compare this to the number of nurses in the UK alone, which is 700,000 or so. So we are still small. There is some data as well to suggest that that kind of anecdotal experience of having people look a bit confused when you say I'm a genetic counsellor is sort of reflected in wider attitudes and understandings. So there's a survey done in 2018 in Canada, and about over 2/3, about 69% of people had not heard of genetic counselling. And also some sort of follow-up questions from that showed that about 3/4 of people thought that the aims were to just about preventing genetic diseases and helping couples have children with desirable characteristics or understand their ancestries. You know, not only was a kind of a lack of awareness perhaps, but also perhaps misunderstandings. Similarly, a survey from the United States in 2014 found that about half of their responders had not heard of the term genetic counselling. And a recent survey from Jordan again found that around 20 people had heard of genetic counselling. And again, the follow-up questions of those that had heard, many had sort of got some what we might consider misunderstandings about what it is and what we do. So, you know, I think, you know, there is still work to do in terms of thinking about how we, you know, can kind of communicate our professional identities and raise awareness of what we do and our approach to genomic medicine. And I think the first kind of concept from science communication is going to be one that's very familiar to kind of genetic counsellors in terms of our approach to communication, which is you know, to avoid deficits, which is a long-standing kind of theory from science communication. There was a big shift in the world of science communication in around 1985, at least in the United Kingdom, the publication of something called the Bodmer Report, which marked this sort of well, at least rhetorical, if perhaps not always reflected in practice, shift away from this idea of deficit theorizing. So deficit theorizing is essentially top-down, hierarchical. It's about education. It's about understanding misconceptions and then, you know, aiming to find out what people don't know, what they're wrong about, and kind of, you know, educate them. This often stands in contrast to what is considered the dialogue model. So, you know, there's often these kind of two models in science communication that stand in contrast to each other. Dialogue model is probably a bit harder to define, but essentially the key is that, you know, you can't see publics as empty vessels. You have to see communication as going multiple ways. You have to see, you know, the kind of the complexity of the ways in which people understand it, you know, the key point, I guess, is that what you might consider a successful science communication in a deficit model, it's about kind of transfer of information, transfer of knowledge, whereas in the dialogue model, it's more about facilitating a kind of conversation and facilitating dialogue, as the name would suggest. I think one of the key things, as the kind of cartoon shows you, I mean, you know, deficit theorizing in science communication has sort of persisted, and, you know, many people have said, you know, it's appropriate to be able to understand what people don't know or what they have misconceptions about, and that's important. And there's a long, complex debate around this, which we don't have time for. The key thing is that deficit models, you know, are, as we will know from clinical practice, an ineffective way of communicating with people. You know, essentially by this cartoon kind of sums it up really well. You know, so you go to somebody, let me tell you why you're wrong. Someone is not going to say, wow, thank you so much. You have to have different ways of starting the conversation. When you're slipping in, you know, one of the big lessons from science communication is that when you are slipping into deficit theorizing, you are unlikely to be doing compelling or engaging science, you know, communication. Another thing I think we can take from science communication is that we can take a slightly, you know, historical perspective on professional identities. It's interesting, if you go back to 1830, when scientists themselves were creating their own identities, we can see how you know, they were negotiating those identities and their authorities at the time. So in 1830, the scientist Charles Babbage published this work on reflections of the decline of science in England. What's interesting about this is actually a year before the term scientists themselves, you know, they were coined as a professional, sort of, as the name to characterize this kind of new and emerging, you know, professional group. What's interesting here is that even at this point, one of the ways that scientists tried to establish their identity and authority was by engaging in all sorts of science communication. The British Association for the Advancement of Science was formed kind of following this kind of publication. And they then kind of went on a sort of blitz of science communication. They kind of organized great spectacles and demonstrations about science. Of course, this had this had a aim of trying to establish their professional identity, but then it also became combined with all of the other kind of political and social climates of the time. So of course it became involved in demonstrating both kind of the might and the power and the moral superiority of science, and then also the British Empire. So I think this kind of brings me on to kind of the second concept, which sort of follows from the first about deficits, is that you can see from the very beginning of science, when science communication is sort of first establishing itself, at the beginning of the period where scientists themselves are becoming a professional body, is that you can't just communicate the facts. And we sort of think about this. We can't just communicate what it is that we do. It's not in a neutral way. It's a deficit assumption in itself, essentially, but then we have to understand how this is situated in the broader context of the political and cultural concepts of genetics and genomic medicine. So I think in sort of the aim, context of wanting to communicate professional identity, we also have to be aware of the broader strategic aims of what we're doing, the broader social and political climate, and how that's kind of going to influence what we're doing and what we're trying to do. And it's just to sort of try and move away from the idea that it's as simple as just finding out that who doesn't know about genetic counselling, and then kind of transferring that knowledge to them in a successful way, because they will be bringing their own beliefs, their own cultural attitudes about genetics, genomics, genetic testing, whatever. And we'll come back to some of this a bit later, and to see kind of just how important it is to make sure that we don't just see it as a kind of neutral act, that we understand the kind of complexities of that. And this again kind of follows on from that point, which is that it's not really what we say, it's what we hear that's important. That's what people hear. That's not what we say, it's what people hear that's the important point. So this is something that, again, I think probably quite familiar to people from a genetic counselling background. But when we communicate, people will interpret that in using their own knowledges and experiences. And we've seen this, for example, in some of the work that we've done that's looked at how people from minority ethnic backgrounds understand different genomic messages. And we found that certain messages will be interpreted in very specific ways, particularly based on historical and current forms of discrimination, and people's awareness of those. So, for example, people from minority ethnic backgrounds, when you led with messages that focused on the kind of collective benefit of genomics and genetics, actually that was treated with a quite high degree of cynicism, because of people's experiences that are shaping in the way that they see those messages. So it's not just about the crafted messages that you think are compelling, it's then trying to understanding what people hear when you say that. And we can see there's a recent example of a research study called Spectrum 10K, which has found it really difficult. They've been trying to research some of the different complex aspects of autism. Part of that study is sequencing the genomes of 10,000 people with autism, but that community has in parts found that quite challenging, because when somebody says, I'm going to sequence the genomes of 10,000 people with autism, that's what you say, but what they hear is this is eugenics and you want to get rid of people with autism. So it's a very kind of stark example of how important it is to understand the difference between what you say and what people hear, which again is something I think is going to be very familiar to people from a genetic counselling background, understanding the idiosyncratic and personal ways that people make sense of genetics. But the same thing is going to be happening when we're talking about our professional identity. It's not just a case of communicating it, it's understanding that when you communicate that within different groups, that people are going to hear that in particular ways. And we need to understand that in order to be able to communicate that in a way that is going to be meaningful and acceptable to different groups of people. And then sort of the final concept that I think is useful, that I think I'm hoping kind of ties some of these ideas together, is the concepts of a hybrid space. which is a new idea that's kind of come out of some of the sort of science communication research, which has been looking at the different ways that you can bring knowledges together in order to both communicate science and also develop different sort of science communication messagings and approaches. And the idea of a hybrid space is that you allow different forms of knowledges to come together, and you allow those tensions that exist to exist, and you can see those as being useful tensions. It comes from a form of education theory called funds of knowledge. Funds of knowledge was an education approach that started out in the sort of southern United States, where there was lots of schools that sat on the border between the USA and Mexico. And the basic idea was that from children who are from typically underserved populations, or populations who had lower educational outcomes, which is often the Spanish-speaking Mexican students, approaches that had formed a sort of deficit theory. We need to improve their education because they're underperforming, but continually failing. And one of the ways that they managed to improve outcomes was by flipping it and saying, okay, well, let's bring in their knowledges, their experiences into the classroom and use that to shape the learning experience, even though that there may be tensions or perhaps or differences between their knowledges, their experiences, and the teachers, who are predominantly from kind of white American backgrounds. And they kind of characterize these as funds of knowledge, these kind of knowledges and experiences that students had from their own lives. And then that's then been kind of taken forward, that you kind of bring in different people's funds of knowledge into spaces where you can allow those to sit alongside more kind of formalized or expert sort of types of knowledge. And it's about understanding what those tensions are, but seeing those tensions as not necessarily negative, but understanding how they can feed into each one another and how they can be useful. So to give you an example, perhaps to make it a bit clearer, just in the last minute or so from genetics, you can think about that in a clinical space, where somebody might have a different view of inheritance to the sort of Mendelian. They might say, oh, I'm not worried about this, BRCA mutation because I take after my father and this comes from my mother's side, for example. Somebody might say that. And the temptation there is to kind of slip into a kind of educational deficit type model and think, okay, I need to address this misconception, which I guess you do, but at the same time, that tension is a useful one, because that's going to allow you to understand the emotional significance of that patient. It's going to allow you to understand what that means. You need to explore it in a way that allows that tension to the perhaps Mendelian form of the inheritance, which you may be wanting to kind of put forward as a genetic counselor to exist in that space in a way that is going to be useful in coming to the ultimate understanding, which is what does this test mean for this patient. So I think in terms of understanding, how we can communicate in a professional identity, I think it's kind of useful to have this view as a way of thinking about how can we communicate that in a way that isn't just about trying to think, well, I've got to package up a genetic counselling identity and then just kind of go and give it to lots of people, because that's not really going to work. It's like thinking about how do we create spaces where we can allow different views about genetics, genomics, going back to the Spectrum 10K, different people who may feel threatened by the idea of genetic testing or genomics, or talking about the inherited nature of different conditions, conditions that may have been stigmatized for whatever reason. How can we allow those different views to be brought into the discussion in a way that even if there's tensions, those tensions can still be useful in understanding what our identity means for different people. In other words, when we say identity, what we say is one thing, but what do people hear is another. And I think a hybrid space is an interesting way of thinking about how we can go about exploring that. So just some conclusions. I think we do need to think about how we can communicate our professional identity. So what it is we do, what our approach is to genomic medicine, and to advocate for that, to advocate for genetic counselling, genetic counsellors, that approach to genomic medicine. So thinking about how we kind of formulate and communicate our professional identity. But in doing that, we need to avoid that kind of deficit thinking, and that's a clear message from science communication. It's not an effective way of communicating, and it's one of those things where the approach to deficit thinking is something that's very easy to agree with in principle, but is often harder to put into practice. And we've seen this in science communication, where there's been a strong rhetorical and ideological shift away from deficit thinking, but practically it can be quite difficult to do that. So it's kind of having that present in our minds about thinking, are we slipping into this kind of deficit thinking, because we know that that's not going to work. So what to do instead? Well, one of the things that I hope would be kind of very comfortable to genetic counselling is that actually you often start by listening first. So it's that thing of understanding what it is that people hear when you communicate, not what we say, because that's the key thing. And one of the ways to be able to do this is to think about this idea of hybrid spaces. So allowing different voices, maybe disparate voices or contentious voices or tensions to exist, and seeing those not as obstacles to be overcome, but useful ways of being able to understand what people are thinking, feeling, hearing, and using that as a starting point for kind of communicating what we do. So I hope that this has kind of given some kind of useful points of reflection in terms of how sort of some of the sort of theories and research from science communication can help us when we're going about communicating our professional identities. So thank you very much for the opportunity to present today.
Dear colleagues, I would like to thank the program committee for the opportunity to present information about genetic counseling and testing in Russia at this Congress. I will start with a few facts about the history of genetic counseling in Russia. Then I will talk about where genetic counseling and genetic testing is done now, who can become a geneticist and laboratory geneticist. The next section of the presentation is devoted to pilot projects for genetic testing, which started now. At the end, I will touch on some of the problems. Genetic counseling in Russia has a long tradition. You see portraits of two scientists who started genetic counseling in Soviet Union. The first genetic consultation at the Medical Genetic Institute in Moscow was opened in 1929. The director of this institute was Solomon Levit, and the director of the consultation was Sergei Davydenkov. In 1932, Davydenkov moved to Leningrad and opened a second genetic consultation at the Department of Nervous Diseases. Unfortunately, genetic counseling shared the tragic fate of genetics in USSR, and since 1948, all researches on genetics was stopped and genetic counseling was closed. Genetic counseling began to revive at the late 60s. Genetic consultations in regional health care system were organized since 1969, and the training of geneticists began. The Institute of Medical Genetics was opened in Moscow in 1969. Now it is a research center for medical genetics. It is the largest research and clinical center in Russia where hereditary diseases are studied. There is another research genetic center in Siberia, in Tomsk. This is the Institute of Medical Genetics, founded in 1985. There are two genetic medical specialties in Russia. The medical specialties of genetics and laboratory genetics were officially recognized in 1988. The geneticists provide clinical diagnostic of hereditary diseases, treatment of certain metabolic diseases, and genetic counseling. Laboratory genetics have subspecialties of cytogenetics, biochemical, and molecular genetics. Physicians trained in pediatrics or therapy are usually genetics. Laboratory geneticists are usually physicians trained in medical biochemistry. The residency in genetics and laboratory genetics has a duration of 2 years. The certificate obtained after the end of the residency must be confirmed every 5 years. More than 400 certified medical geneticists and about 500 laboratory geneticists and biologists are working in various institutions of the genetic service now. The genetic service in Russia is represented by 2 sectors: federal and regional genetic centers in healthcare system and private genetic laboratories. 76 regional centers operate in healthcare system in 67 regions of the country. Examples of regions with large genetic centers are shown on this slide. Regional genetic centers are usually located in large regional hospitals or perinatal centers. This allows geneticists to collaborate with doctors of other specialties in the diagnostics of hereditary diseases. Federal genetic centers are located in Moscow, St. Petersburg, Tomsk. Genetic counseling and testing in federal and regional centers funded from the state or regional budget or paid for the compulsory health insurance system. Genetic testing and genetic counseling for patients with hereditary diseases is the main task of the genetic centers. Genetic testing in regional centers includes cytogenetic and biochemical tests, fish analysis, and the study of mutations in genes of common monogenic diseases. In addition, the laboratories of the regional centers carry out mandatory newborn screening for 5 diseases. Genetic counseling is offered to parents of children with hereditary diseases identified during screening. Screening of pregnant women for congenital defects and frequent chromosomal abnormalities in the fetus is also carried out in regional genetic centers, as well as invasive diagnostics of fetal chromosomal abnormalities. Pregnant women at risk are also invited to a geneticist for a consultation. The regional register of families with hereditary and congenital diseases and the monitoring of congenital malformations are also the tasks of the regional genetic centers. Another important task is the education of a society for medical genetics and genetic testing. This improves the knowledge of the population, contributes to increased trust in genetics and the efficiency of counseling. Many geneticists appear in media and social networks. Some results of the work of the regional genetic centers in 2020 are presented in this slide. Geneticists in Russia conducted more than 400,000 counseling sessions, examined almost 99% of newborns for 5 diseases, and about 78% of pregnant women in the early prenatal screening program. One of the 5 diseases was diagnosed in almost 1,000 newborns. Parents with the need for more complex genetic testing come to the federal centers in Moscow and Tomsk, which I mentioned earlier. Genetic testing is also carried out by specialized research centers in various fields of medicine: cardiology, pediatrics, reproductive medicine, neurology, etc. Most of these centers are located in large cities in the European part of the country. The Research Center for Medical Genetics, where I work, has a genetic outpatient clinic. Patients with suspected hereditary pathology come from all regions. They undergo genetic testing, including next-generation sequencing, mainly targeted gene panels or exome analysis. Genetic counseling is done before and after testing. As an example, the slide shows the number of families consulted and genetic tests performed in 2020 in Research Center for Medical Genetics. Private genetic laboratories do many genetic tests. Basically, there are chromosomal microarray analysis, non-invasive prenatal testing, analysis of exome, genome, gene panels. Most genomic tests are done in private laboratories. It is often ordered as direct-to-consumer service, and appropriate genetic counseling is not always provided. Pre-implantation genetic testing is mainly a paid service. Genetic counseling is mandatory for this testing. Pilot projects began to improve patients' access to the modern genetic testing in the healthcare system. First of all, there are projects of non-invasive prenatal testing in the program of mass prenatal screening in 2 regions and analysis of the genome of patients with hereditary cancer syndrome. The Center of Obstetrics, Gynecology and Perinatology is carrying out a pilot project for the analysis of newborns' exome. An analysis of ethical issues of testing is carried out additionally in this project. The Russian government has decided to expand obligate newborn screening in 2022. 36 diseases will be tested instead of 5 now. There are mainly metabolic diseases, immunodeficiencies, and spinal muscular atrophy are also on the list. Biobanks and genetic databases projects started in research centers. There are about 190 ethnic groups living in Russia. It is important for us to know the mutation frequencies in different regions and different ethnic groups. It is already known that in some regions there are high incidence of hereditary diseases, usually associated with the founder effects. These projects are important for the development of genomic medicine in Russia. Plans to expand genetic testing and screening require more geneticists and laboratory geneticists than now. Only private genetic laboratories exist in some regions. Regions in which there are no geneticists in healthcare systems are marked with light on this map. Telemedicine consultations help reduce the problem, but it cannot completely replace the communication between the doctor and the patient. Training more geneticists and laboratory geneticists for healthcare is becoming a top priority. Another important task to be solved in the near future are the development of telemedicine, the creation of genetic databases for different ethnic groups in Russia, the expansion of genomic testing for public health purposes, and the expansion of the newborn screening program. In conclusion, I would like to thank Sergei Kutsev, Chief Geneticist of the Ministry of Health of Russia, for the data on the genetic service of the healthcare system, and my co-author, Helena Baranova. Thank you for your attention.
So good morning, and thanks to the scientific committee for selecting this work to be presented. My name is Adrià, and today I'm going to present the results of the ARPA study on behalf of the authors regarding the risk profiles of psychological distress after cancer susceptibility genetic testing. So far, we know that genetic testing for cancer susceptibility causes an immediate psychological impact that tends to return to baseline levels after 1 year. We also know that positive genetic test result, prior cancer diagnosis, having children, and family history of cancer are predictors of high psychological impact. A prior analysis in a small cohort suggested that uncertainty was higher in individuals with a moderate penetrant breast cancer pathogenic variant carriers compared to those individuals with a high penetrant breast cancer pathogenic variants. And since genetic testing is perceived as a vital event for many individuals, we had a hypothesis that personality traits may influence the psychological impact of cancer susceptibility genetic testing. With all this in mind, we aim to describe the psychological impact after genetic test result disclosure in a diverse cohort of individuals undergoing cancer susceptibility genetic testing. We also aim to analyze the predictors of psychological outcomes in individuals undergoing cancer susceptibility genetic testing, to identify risk profiles of psychological impact after genetic test results, and finally to compare the uncertainty levels between moderate and high penetrance breast cancer pathogenic variant carriers. For this purpose, we designed a multicentric longitudinal prospective study within the 5 centers of the Catalan Oncology Network, and we included patients undergoing cancer susceptibility genetic testing in our hereditary cancer units. We assessed demographic and clinical data at the baseline, and also psychological variables such as personality traits and cancer worry through the cancer worry scale. 1 week after the in-person result disclosure visit, we also assessed genetic data and again, psychological impact from genetic testing through the micro scale and again, cancer worry scale. And 3 and 12 months after the result of the result disclosure, we assess again the micro scale and the cancer worry scale. The Melphi Inventory assesses the personality traits, and it's based on the Big 5 personality traits theory. Here we can see the 5 personality traits, which are neuroticism, extroversion, openness to experience, agreeableness, and consciousness. Regarding to neuroticism, we know that people who score high in neuroticism, they tend to emotional instability, and they are bad when coping with stress. In contrast, people who score low in neuroticism, they tend to emotional stability, and they are free from negative feelings. On the other hand, the micro questionnaire assesses the psychological impact from cancer susceptibility genetic testing, and it provides a total score, and also it provides a 3 subscales score. These are distress and uncertainty subscales. Then this is a very specific subscales, and they show the bad reaction from the result, and then the positive experience subscale that is related to how the genetic test result is perceived as an opportunity. For the first aim on the study, we performed the descriptive analysis of the distribution of the micro scores. Then for the second aim, we performed multivariate regression analysis, and we included all the demographic, clinical, and psychological variables, potentially predictors for the micro scores. And finally, we combined the significant variables to create clinical profiles, and we sorted them by the micromean of the subscales. Here we have the study population. We included 714 patients. They mainly were women, 75% of them were women. 55% of them were diagnosed with cancer, mainly breast, ovarian, colorectal, and prostate cancer. 56% of them underwent panel testing. 26% of the results resulted positive. As we can see here, 55% of the population scored high in neuroticism and low in consciousness. Regarding the first aim of the study, we can see here the distribution of the micro subscales. We have to remember that the micro uncertainty and distress subscales indicated a bad reaction to the result. And we can see that in 3 times after result disclosures, 3 months and 12 months after the result disclosure, the scores, most of patients scored low in this subscale, as we can see here. And in contrast, in the micro-positive experience, patients score high, up to 20 of score, as you can see here along the time points. I show here the results of the univariate and multivariate analysis for the micro distress scores, and we included all the clinical relevant variants, and we can see here that this analysis showed that a positive result, a high neuroticism group, and high cancer worry baseline were predictors of the micro distress after the result disclosure. And for the micro uncertainty, again, we saw that positive results, high neuroticism group, cancer worry baseline, and gender were related with the micro uncertainty score. Here there is a summary of the predictors of both distress and uncertainty. As we can see, positive result, high neuroticism group, and higher basal cancer worry, together with woman gender in case of uncertainty, are predictors of psychological outcomes after cancer susceptibility genetic testing. As I mentioned before, we combined those significant variables to create clinical profiles. And we can see that women with high neuroticism and a positive result are on the top of the ranking scores. And in the first 4 profiles, we can see here that for distress subscales, high neuroticism and positive results are represented in this score, in this ranking. And we can see that 10% of individuals of our population scored were women with high neuroticism and positive results. And for uncertainty, we can also see that high neuroticism are on the first 4 profiles of the ranking scores. And finally, for the last aim of the study, here we have the uncertainty score levels here on the y-axis. And we compare the high breast cancer penetrant carriers with moderate breast cancer penetrant carriers and with non-carriers along the time points, and we can see that there were no difference between high versus moderate penetrant carriers in the result disclosure 3 months and 12 months after the results. The only significant differences were seen between carriers and non-carriers. And with all this, we can conclude that in most cases, the result of cancer susceptibility genetic testing did not produce a high psychological impact. Positive results, high neuroticism, high basal cancer worry, and woman gender predicted the psychological outcomes of cancer susceptibility genetic testing. 10% of individuals in our population seen in our units had high distress profiles. Levels of uncertainty were not different between carriers of high and moderate breast cancer penetrant genes. And this can be used in the era of personalized medicine. Genetic counseling for cancer susceptibility should be adjusted according to psychological background, for example, neuroticism or personality traits itself or cancer worry. I want to acknowledge all the colleagues that have been involved in this project and the audience for attending. Thank you very much.
And I know a lot of people say, does this life really exist? Well, that's not my personal perspective. For me, whether it's a 6-week termination, you're taking away a life, that's my personal perspective, not based on religion or anything, but that's my belief. And I think it's quite hard to think it's justified. So I struggle with that pretty much all the time. And thinking about how to feel about the woman, I feel it's difficult going through that. How must they feel, and feeling that sometimes my stuff shouldn't matter because actually their burden is so much greater. This is the experience of just one of the health professionals in this study. What is key here is how their professional self and empathy for the woman puts their personal feelings aside and focuses on the woman's experiences. Good day, I am Malebo Malope, and I'll be talking to you about my study on health professionals' experiences and perceptions on termination of pregnancy for serious congenital abnormalities. Working with women who have fetuses affected with serious congenital abnormalities can be difficult for health professionals. They can be faced with having to navigate prenatal options for the woman while remaining within the laws of the country. South Africa's Termination of Pregnancy Act is quite liberal compared to many African countries. Termination of pregnancy is permissible up to 12 weeks gestation on demand, and after this is for fetal anomalies and maternal factors. Late termination of pregnancy, which is after 24 weeks, is also allowed for severe malformation of the fetus. This usually requires a feticide. However, the law is not specific on what constitutes a severe malformation. Therefore, to mitigate this, the 2 academic hospitals in the Western Cape province where I recruited my participants are governed by their own internal policies with regards to feticides. Should some of the women decide to continue with their pregnancies, they will encounter other health professionals, including the nursing staff and the doctors from the antenatal clinic, other pediatricians from the neonatal wards, and also others from the labor ward. As the code illustrated, healthcare professionals have their own views and perceptions on termination of pregnancy for serious abnormalities, and thus this study explores their experiences and perceptions on the woman's decision-making process. Ethics approval was obtained from the UCT Human Research Ethics. I recruited the participants using email, posters, and word of mouth. I obtained ethical approval, informed consent from all of them, and this was a qualitative study. Therefore, I had interviews, and all of them were in person, or they were telephonic, and they were audio recorded and transcribed. The interview questions were semi-structured and open-ended, and I analyzed the data using thematic data analysis. This is the demographic information of all my participants. They all had a wide age range from 30 to 56, and also their years of experience in their respective fields also varied. They were all cisgendered and identified as either male or female, and majority were female, and they all came from the different disciplines, with most being obstetrics and gynecology, mainly because they comprised of the fetal medicine unit, labor ward, and also antenatal clinic, and most of them had 1 or more children. 3 main themes came from the data, and this was personal views and how they feel about the topic, what their professional role is within this space, and also what they perceive the women's experiences are. Health professionals are required to facilitate the woman's decision-making process regarding termination of pregnancy and support that decision. However, they're constantly navigating their own personal views on termination of pregnancy for fetal anomalies. Would they consider it for themselves if they were in a similar position versus their professional role where they need to break the bad news while struggling with which conditions meet criteria for feticide and dealing with uncertain prognosis of some of these conditions? Often their personal views conflict with their professional views, and there's a clear divide, but they put their feelings aside and remain professional. The quote I read in the beginning is a clear indication of this divide, and they even ask themselves if termination of pregnancy for certain conditions is even justified. Regardless of this, they aim to be non-directive while communicating with the feelings. This quote is from participant number 1, and she felt that it is okay to terminate in certain circumstances, although it didn't always align with her religious beliefs. Someone will want to terminate, and I think that's probably not a bad idea. Although from a religious point of view, I'd rather have the pregnancy ending naturally rather than me terminating myself, because then I won't feel the guilt of it. But religiously, one would ask then, but why do you sometimes say it's okay? So like for me, sometimes I feel it's better rather to just terminate the pregnancy because the circumstances seem like it would probably be a better idea. Some of the participants identify with the women, especially those who've had children with themselves or children with or family member with a genetic condition. This also influences not only their view on termination of pregnancy, but also their view on the perceived quality of life. Participant 10 has a child with a genetic condition and really identifies with what the women are going through. And they said, I can understand more about what they're going through. I spoke about the different levels of disability and how you can actually adapt. Every child doesn't have to be perfect. You can still have a good relationship and enjoy life depending on the level of disability. The health professionals really empathize with the woman, and all of them agree that there is actually no easy decision for them to make, whether to terminate or to continue with the pregnancy. And participant 4 summarized it nicely by just saying what they all say in the interview is they make the least worst decision. Healthcare professionals believe in non-directive counseling, and they offer for the woman to have their partner's family or someone they trust present during the session. They do struggle with offering termination of pregnancy for conditions with an uncertain outcome or variable outcome because they can't give concrete information with regards to the outcome. Termination of pregnancy for these conditions cannot be justified to themselves. And one even highlighted that the patients will then focus on the less severe outcome as they try to remain hopeful because you're giving them this variable spectrum of the outcome. The fact that I don't have every single exact outcome for that makes it hard for me because the more people try to hold on to hope, you want to latch onto it as well because they are in such a hard and such a difficult space that you want to actually make it better. Then I have to step back and know that my making it better is by helping them understand and not making it less severe, but by making it more understandable so that they can make their decisions. And this is how participant 4 navigates the space of uncertain diagnoses. Most of the healthcare professionals believe that women should always be empowered to make their own decision at the end of the day, and that your personal perspective should not impede that. Participant 9 said, I mean, because you cannot impose your way on the patient. So you just need to counsel the patient and give them time because, as I say, it's not an easy decision. It's a matter of time, and then non-directive counseling. The decision-making should be left to the couple or the mother to decide. Yeah. Their concern for the woman was highlighted by their mentioning the needs of the woman from the time of diagnosis, termination of pregnancy, or until delivery and during postnatal period. Some suggestions include continued psychological support for the woman, allowing them to have a separate delivery room instead of having delivery in the same room with healthy fetuses, and meeting parents with affected children to allow them to be able to make the right decision for themselves. They are also reflective on the women's experiences, and from their own personal experience, provided reasons why they would think women continued with these pregnancies. And these include things like religion, shock or disbelief and denial, inability to visualize the abnormalities on ultrasound, lack of understanding, having hope, whether it's true hope or it's misguided, and others just accept the diagnosis, but termination of pregnancy is not an option for them. And importantly, with our population making the decision as a family and it being a precious pregnancy. Termination of pregnancy for fetal anomalies always raises personal concerns for health professionals. Some are conscientious objectors based on various reasons, while others offer the service while experiencing some internal turmoil. It was interesting to see that this resonated with the health professionals in this study, where they also experienced some internal conflicts. On the one side, they support offering termination of pregnancy for fetal anomalies, and on the other side, their personal beliefs do not align with that. This has been found to cause some emotional distress and professional identity in participants of previous studies. It is not unusual for health professionals to offer termination of pregnancy for fetal anomalies, especially feticides, even though they would not consider it for themselves. There is literature discussing uncertain diagnoses and termination of pregnancy, and even more on the ethics of termination of pregnancy in certain circumstances. However, there is still no clear solution on conditions with a variable or uncertain outcome. And in South Africa, it is worsened by lack of a clear definition of what constitutes a severe malformation. In conclusion, it is quite clear that we do need a better definition of what a severe malformation is, and also better direction on when should you always offer a termination of pregnancy on uncertain diagnoses. Health professionals do need emotional support, and this can be either from their colleagues and also have access to a therapist who will always be available for them. A separate labor ward is needed for women who are either terminating their pregnancies or who are continuing these pregnancies, and they need that continued psychological support. Health professionals in the study showed that they do have ideas on how we can improve the health care of the women. However, none of them seem to implement it. And I think we do need more open discussions surrounding this topic to improve the care for both health professionals and the women. These are my references, and I would like to thank my supervisors, my funders, and more especially my participants. Thank you.
Welcome to this question and answer session from this 5th session, which was 4 very interesting talks. I will ask some questions to the speakers, and I also hope that we will have a panel discussion among these questions. So I will start talking and giving questions to John. You got a question like, I would be more interested to know how you feel genetic counselors can apply science communication concepts to communicating within mainstream clinician colleagues.
Yeah, I like this question, but I don't think there's going to be a simple answer to it. I guess it depends about what we mean by communicating to colleagues. So I think if we're talking about communicating kind of a professional identity, which is sort of some of what my talk was about, then I think it comes back to kind of owning that agenda and not being shy of it. I think, we're more effective communicators when we know what our agenda is and what we're trying to achieve. And I think, as I tried to show with the kind of historical angle, science communication has always had an agenda. So I think it's about, being clear about what we're trying to achieve when we're, going out and advocating for our professional identity. And I think we'll be more effective when we are honest about that and we own that. If it's related to sort of communicating about genetics, which I guess we're sort of doing on an increasing basis as we're sort of mainstreaming, I think the useful lesson you can take from science communication is just how ineffectual deficits are. So deficit model is as communication. I mean, it just feels so natural when you're faced with, a situation where someone seems to learn less than you or has got, a scientifically inaccurate perspective or whatever, to want to correct them. But, one of those key messages that you see replicated in so much of science communication is that as a communication strategy, a simple deficit model is really ineffective, and especially ineffective when you're trying to influence someone or change their mind. So I think, it can be just a useful, sort of thing to have in the back of our heads when we're kind of communicating with colleagues,
So a follow-up question to that, what do you think are the stressors or the circumstances that really make the deficit model reappear in a way? So what are the stressors for that?
Yeah, I love this question too. And again, there's so much to unpack in that. I pull out 2 things. I think one is an internal thing, and I guess this comes back to, I think, why genetic counselors are kind of well suited to this, that kind of, internal supervisor, because I think sometimes that's an personal thing. We are, sort of taught, there's a learned behavior that when someone says something wrong, you want to kind of correct them. In my head, I always think of this as like the QI problem, the TV show QI. The whole thing is set up for someone says something wrong, and then somebody says, aha, this is why it's right. And that kind of dynamic, and actually, it's a learned thing about, learning what to do when you're faced with a situation where somebody either knows less than you or is presenting a view that you think is inaccurate. But then I think what's quite nice about some of the science communication research, especially that's kind of come out of the education stuff, is that it's also about all the different factors that can affect how deficit model can kind of reappear. So a lot of those around power dynamics. So they did some really nice research that showed that the orientation of a classroom, for example, in science lessons, can allow different voices, and the children's voices, especially children from marginalized communities, allow their perspectives to come into the classroom. And we know that from our clinical work, how you set up the desk, how you sit, what you're wearing, if you put on a white coat and sit behind a desk, people are not going to feel as able to speak as if you're sort of sitting around a table and you're wearing, less formal clothes. So I think there's all sorts of ways that those deficit models can come in. Some of them are external, to do with how power is structured within a clinical consultation, and some of those are just internal things about how you have learned to respond when you feel that someone needs correcting.
This is a follow-up question for me, just that very shortly before I go to the others. But do you think that not only education, our own skills, it's all like experience, and when you feel like very comfort in your way of giving genetic counseling, it's easier to not fall back? Do you get what I mean? So it's more like when you feel safe in your professional role, it's easier to not follow the things you learn from the start, or how it was from the start.
Yeah, if I understand you right, I think I remember I sort of think back to some of my early genetic counselling consultations and cringe, because what I would have used to do was learn everything about the condition, then sort of spew it at patients as if they needed to know everything, and that was born out of insecurity, and I think as I have got more secure in my sense of professional identity and professional competencies, I feel more comfortable sitting back and letting the consultation happen. So I think there is an element at which, and that goes back to some of that's an internal thing and a security thing. And I do remember, when I was learning that, I felt that if I absorbed all the information, packaged it up, and then just gave it to the patient, I'd somehow done my job really well, and that was, problem solved. And so I think, there is an element of how confident you're feeling and secure you are about the job that you're doing that allows you to sort of sit back and let go of that educational agenda.
Thank you. And I think that goes well then into the next questions to Adria about, this is receiving, giving information or giving counseling, and then we need to talk about how it is perceived, and your talk about the personality traits of the counselees. And one question first, you talk about the different personality traits, but when we come to neuroticism, can you please explain a little bit more what it means and what traits does it include, just to have that as a base?
This is a very important personality trait, and it refers mainly to the emotional stability. So people who score high in neuroticism, they are bad when coping with the stressors. They respond poorly to environmental stress. In fact, high neuroticism, it is related to negative feelings, to negative affects, and to negative perceptions, such as anger, anxiety, or irritability. So it's bad. People who score high, they live worse. And in contrast, low scorers, they seem that nothing affects to them. They are so stable when reacting to life events. So it's the opposite, and it's a good way to live life, being low neuroticism.
Okay, thank you. And how do you think we can use these different personality traits in our counseling profession and in the meeting with the counselor?
Yeah. I think that's the point of this research, and I think that mainly in the way how we communicate with patients, as Jonathan said before during the presentation, it's not what we say, but it's what patients hear or what people hear. And we are now developing strategies for improving our communication skills and adapting these skills to the personality traits. For example, we know that in people who score high in neuroticism, we have to be clear with them, and we have to guide them on what they have to worry about. That's one way, for example, to decrease their potential anxiety or worry. And we have seen also that, sorry, Charlotte.
No, go on.
And we have seen also that when implementing, for example, telegenetics or non-in-person visits, we know that people who score high in neuroticism, they are less likely to accept a telephone visit, for example. They prefer in-person visits, people who score high in neuroticism.
So do you mean we should use them? Should we score all patients?
Why not? Why
Okay.
not? Maybe it's challenging, and maybe we have to change our skills, or maybe we have to improve how we perceive how the personality traits of our patients, but why not we can incorporate them to our clinics? We have to think all about on how we can do that.
Really interesting. So you could imagine patients in a waiting room waiting to go in and then doing a personality profile before they're seen, and then you do a quick score and then adapt how you're communicating. And I was just sort of imagining if a counsellor is in deficit model mode, so information giving, but a patient is highly neurotic, how that's going to be very mismatched.
Yeah. And as you said, Anna, I think it's a way of personalized medicine also to adapt our communication skills to personality traits. So it's another way, another approach to personalized medicine, especially in oncology. That's
a very interesting idea. Yeah.
And maybe you could have it not in the waiting room. Maybe you could send it with an invite, and then they can online score it, so you know in advance. But I think it's really interesting. I think I would come back to Malebo then, and then I would come to Helena a little later. But Malebo, I think it goes hand in hand. You talked about the uncertainty and when you have a fetal anomaly, which is very severe. And the question is, which was actually a little bit my own question, that when you're in a fetal, certainly in prenatal, you have to make decisions on uncertainties. And the more we can do, the more uncertainties we will get. But even in the trisomy screening, we have uncertainties of the expression of the syndromes. So even there, it's a big problem. And how can we help patients or women or couples to make decisions based on their way of coping with uncertainties instead of more and more facts? Because we cannot get more facts. And is that related to personality traits then? It's a second question. But how can we cope? How can we help people to deal with uncertainties and make decisions on that?
Thank you for your question, Charlotte. For me, I think it's being honest with your patients from the beginning, letting them know that this is very uncertain. Because when you try to cover it up, often patients can tell that you're kind of being dishonest, and they can see your discomfort. So being honest with them from the beginning that we are unsure about the outcome, we can't tell you exactly how it's going to be, but this is what we're expecting. And you as a family, how would you be able to deal with a situation where you don't know what the outcome is going to be? And I think more importantly, we must explore the patient's support at home, because at the end of the day, if this child ends up being on the more severe end of the spectrum, they're going to need a lot more support than we can anticipate. So it's basically preparing them for sort of the worst outcome, but also informing them truthfully that they could be a better outcome. And for now, let's just focus on getting you to delivery and keeping you and the baby as safe as possible until then. But honesty, I think, is always the best policy for your patients, is letting them know that we are unsure, and this is where it could happen, or what could happen with the baby or the fetus. And we know that with fetal anomalies, some of them might also end up in intrauterine death, and that's also important to let them know. So it's containing the different possibilities for them without giving them too much overwhelming information, because that's another important thing as counselors. I think John said it earlier, that often we want to give them all this information, but it does become overwhelming. So give them the range of possibilities, but contain it and be honest with them.
Yeah, and to see how it would affect their family. And do you think there would be, this is also a question, do you think it would be possible to create some kind of decision aids or even scoring like Adria for personality traits, but how you cope with uncertainties to be able to, individualize the sessions?
I think you could. I think there's been quite a few research on dealing with uncertainty, and not obviously related to prenatal that I have seen, but for different congenital conditions. If we have the same view and do research in how patients have coped with uncertainty, how their families found it, what the outcome was, I think that is the first step to helping us find ways or making decision aids for them. It would be quite difficult to start a decision aid or decision-making aid for patients without actually knowing or trying to understand what the experience is with dealing with uncertainty. Looking at our patient population here in South Africa, and I'm only talking about the ones in the state hospital, A lot of them are quite religious or still quite cultural. So for some of them, the uncertainty doesn't matter as much, and it's more knowing what they could expect. And they seem, when they have support, they seem more accepting of what the outcome is going to be. So it comes back to individualizing it for your patient's needs, but definitely more research on dealing with uncertainty in the prenatal setting is needed.
One more question for you is a quick. You talked about the therapists for the healthcare professionals. Is that the same type of counseling or supervision that we talk about, counseling supervision?
The one I'm referring to remember, the health professionals I had were across the board. They were from genetics, fetal medicine unit, and neonatology, which falls under pediatrics. So the counseling that I'm referring to that they need is actually a psychologist or a registered counselor who's made available specifically to them, and made available on like a monthly basis as we would have our supervision. But in addition to that, made available for whenever they have a difficult case, because I know from time to time in prenatal, even as the healthcare professional, there's just that one case that is really, really hard for you to wrap your head around, or emotionally, it really took a lot from you. And at that moment, you really want to talk about it, but often you find yourself in a position where you can't discuss it with your colleagues for various reasons. I mean, in the research that I read about, people find it very hard to discuss with some of their colleagues honestly about how they're feeling about certain things, or offering termination of pregnancy, or not offering it in certain circumstances. So having someone like that who's readily available, not to debrief like on a monthly supervision as you would, but to discuss your emotions, how it's making you feel, and your professional role would be very, very important for us.
So it is that type of psychological or counseling supervision in a way, but more on a regular basis. Thank you very much. We have Helena Baranova here today as in the question and answer session, who is covering up for Vera, who couldn't make it. So I have a few questions for you as well. Vera was talking about the clinical geneticist giving counseling, like she talked about doctors. And is it a specific profession in Russia that are genetic counselors, like non-medical genetic counselors as well? Or is it the doctors that give the genetic counseling?
So thank you for your question. So we have only medical geneticists in Russia. This is doctor, and we have no genetic counselor, but medical geneticist may be a genetic counselor for the patient.
So it's not
we
a
have
specific.
Only one patient.
Okay,
yeah.
So it's not a specific profession about non-medical genetic counselors.
Yes, Russian like German, maybe.
Okay, you were also Vera was also talking about the newborn screening. You said mandatory and you said obligatory newborn screening, and you were going to increase the numbers of disorders in that screening. What does it mean that it's mandatory? What happens if a couple or a patient doesn't want it?
Thank you. Mandatory, it's mean that all newborn children must undergo screening, but parents can refuse screening if they don't want to access newborn screening.
So would you say it as a public program for newborn screening,
it's a public
but you have the right
program.
to say no?
Yes, all for all Russian.
Is it difficult to refuse? So if a parent
no. We have consent for patient. If a patient don't want to sign consent, if no problem.
So it's like a public program. And also
for 36 disease next year.
Yeah.
So that's the newborn. And when we go back to the pregnancy then, and you, Vera also mentioned that the pregnant women are offered an appointment with a geneticist. And does that feature all pregnant women or women with a higher probability for something? Or how do you cope with that in your workflow?
Only high risk women.
Okay. From age, combined test, or high risk in what sense?
We have combined screening for women. If women have risk more than 1%, doctors can explain about risk for this woman and provide invasive prenatal diagnosis.
And then it's a geneticist
test.
Yes, so it's an geneticist. Okay. So it differs a little bit which profession who meet high risk women between countries. Anyone else? Do you have any comments?
Sorry. Oh, she's frozen.
Do anyone else have any comments on those questions or replies that have been put so far to have a more discussion between you in the panel?
I wouldn't mind just picking up on some of the uncertainty stuff because I think it's really interesting. I think like one of the things about, because I think about this quite a lot, and I think there's quite a lot of people looking into it. I think one thing that can help is trying to be a bit more specific about what uncertainty we're talking about. So I guess there's different types. Some of it is just uncertain probability, right? 1 in 4 risk for a recessive condition. Some of it's just ambiguity. You've got a variant of uncertain significance, we just don't know. And some of it's just about complexity. So you've got a whole genome sequence, you don't know what you're going to get back, and there's lots of information. They're all different types of uncertainty. And I think it links into the ideas of deficits, because then I think sometimes we think, we get this with debates about informed consent, as if, if only you could, how is it possible to do informed consent when you're doing a whole genome sequence? Well, that question is rooted in a deficit understanding. And it's also rooted in this idea that uncertainty is something that you need to take away, that it's a bad thing, and you reduce it by giving people information, but it's not. Uncertainty is an inherent part. You can't take away a 1 in 4 occurrence risk. You can't take away an ambiguity for VUS. I mean, you might be able to in the future, but at that point in time, you can't take away the complexity of a whole genome sequence. So the uncertainty is not going anywhere. So I think it's about then reorientating the point of view to not thinking about uncertainty as something that needs to be minimized or taken away, but something that needs to be explored. Now this comes back to, I guess, some of the work about kind of personality types, but how's the best way to foster resilience to an uncertainty? How does someone cope with and understand and feel about it? So I think and then how to do that within a genetic counselling context, within the timeframes that we've got within our areas of clinical expertise and practice. I think it's really fascinating. I think really, really interesting in terms of anything you've got up front in terms of having a bit of information about, what's going to be useful for patients. If you've done some sort of psychometric research to get what their personality type up front is going to be, I think, really useful when thinking about how to, help patients with uncertainty.
There's a new publication on that, but that's not really ambiguity, but there are different types of uncertainties regarding prenatal, which is an international study from different countries, and then they talk more about technical issues, variation of expression and penetrance, and like different areas. But I think this with how can you cope with ambiguity is very important, and that is what we cope with more and more. Certainly in prenatal, but even in other areas of genomics, of course. So I think this is really interesting. Anyone else want to comment?
It's so difficult because we have uncertain information, but yet we're expecting patients to make something certain of it because they're having to make a yes or no or binary decision often. And it's so difficult doing that sort of channeling, that funneling, that you can talk about all the different options and what the uncertainty is, but at the end of the day, particularly with ending a pregnancy, it's a very binary yes or no.
It is binary, but on the other hand, I think it's important to also emphasize and discuss that it is not a yes or no decision. It is a yes or no decision finally, but you would not always know if this is a good decision or not. It's something, certain at some point one of the decisions weigh a little bit heavier, and you have to make decisions. We're used to have control, and suddenly we don't have control, and I think that's something we need to help people to cope with.
Absolutely, and I think that's where counselling supervision can be really helpful, because as a healthcare professional you're left with the decisions that patients make that you may still feel quite uncertain about yourself. And that angst that you feel in relation to those can be really significant.
Just a comment on that, because as I work in prenatal, I often, the people who do, and now it's Down syndrome as an example, but many people that choose to continue the pregnancy with the Down syndrome pregnancy feel that they are questioned in a way by the healthcare professional. And I don't think that the healthcare professional really question their decision, but I think they're afraid that they haven't given enough information. And that is a problem, that they feel that they are, you know, questioned in their decision to continue. And I think we have to think about that, how we talk about that.
Are we out of time? I mean, I'd quite like to ask Elena one last question. Have we got time?
I think we have time.
Have we got time? Okay. Elena, can I ask you, it was so interesting to hear about the services in Russia. Just really quickly, could you tell us if you offer a pre-implantation genetic diagnosis, so testing of embryos in Russia?
In Russia, we have pre-implantation genetic diagnosis for only commercial patients. Only in private clinic, because now our government is not covered this test.
That's really interesting. Thank you. It was so interesting to see the extent of genetic testing and services available in Russia. It was just so interesting to see that. So thank you to you and Vera for that presentation. You're on mute, Charlotta.
So I want to thank all the speakers. We're not running out of time, but I would like to thank you for this nice discussion. And I also want to tell you about the next upcoming session, which is a panel debate on counseling supervision, which I think will be very interesting. So please go there. And then we also can meet in the spatial room to talk over there. And then I also would like to ask you to please go and visit the exhibitors booth in the portal. So with that, I say thank you to all of you. Bye.